Good afternoon. I'd like to start by recognizing that the land that I live and work on is within the territories of the Haudenosaunee, Anishinaabe, and Neutral peoples, and is situated in the Haldeman Tract, which is land that was promised to the Six Nations and encompasses 6 miles on both sides of the Grand River. I'm Richard Ibach, and as the chair of the Waterloo Region Crime Prevention Council, I'd like to welcome you and thank you for joining us at this afternoon's webinar. Crime Prevention Council is a multi-sector collaborative that promotes safe communities by addressing the root causes of social harm. We work as a catalyst for upstream approaches, particularly for those residents who are at a distance from opportunities. We've been very grateful to our regional council for over 2 decades of support for our ongoing work. Yesterday, at another set of webinars that Crime Prevention Council hosted, where we discussed low barrier approaches within shelters, I noted that 40 years ago, in June 1981, the first official report of people who died of HIV/AIDS in North America was published by the Centers for Disease Control. And I mention this because there are concerning parallels between early responses to the HIV/AIDS epidemic and the present overdose crisis that's afflicting our region and so many other communities. In both of these crises, the groups who are at risk of dying were highly stigmatized because of social disapproval of their behaviors and because of their marginalized social positions. In both of these crises, there were barriers to accessing vital supplies to reduce the risks. I remember controversies about condom distribution, safe sex education, needle exchanges in the HIV/AIDS epidemic. We see similar controversies today. In both crises, bureaucratic systems were far too slow to respond, and they overlooked the urgency of the risks. And in both crises, many people died alone and without access to traditional supports like families. As a gay person in my mid-40s who came of age in that era, my sense of identity was shaped by knowing that I lived in a society that didn't care that people like me were dying at alarming rates. But my sense of identity was also shaped by knowing that the communities that were affected by AIDS stood up and demanded recognition of their humanity and fought to change the systems that were failing them. So in this June Pride Month, for me, the most salient message of Pride is the calling to stand in solidarity with those who are fighting against the stigmatization and barriers that are putting lives at risk in our present overdose crisis. Many of you who are joining us today are doing the life-saving work that is protecting those lives, and I want to express my deepest gratitude and respect to you. Today, the Crime Prevention Council is honored to welcome Gab Laurence and Dana Luxinger from the Parkdale Queen West Community Health Center to share some important insights from their innovative approaches to prevent and reduce harm from overdoses in shelter settings. We're very much looking forward to learning from their experiences and considering how those approaches might be implemented within our region. I want to express my gratitude to the incomparable Michael Parkinson for organizing this session. Michael, your dedication, knowledge, and passion for these issues inspire so many of us. I also want to express gratitude to Gab and Dana for sharing their expert insights with us. And I want to thank all of you for attending today's session to learn more about these vital issues. So now I'll turn this over to Michael.
Thank you, Richard, for the kind words. And I don't think I can be more eloquent in drawing the parallels between the early days of HIV/AIDS and the drug poisoning crisis, which continues at record-setting levels. I mean, it was bad 10 years ago. Every year continues to be worse. And just wanted to take a few moments to welcome our guests from Toronto, the Parkdale Community Health Center, who are doing leading-edge work with support from the City of Toronto and so many partners out there during a pandemic. So it's no small thing that they've been able to carve out 90 minutes of their time to share with you today. We know it's busy, to say the least, and lives literally are at stake. I want to take a moment also to welcome everyone from Waterloo Region. If you've been part of the webinars or the research coming from Crime Prevention Council over the years, you'll know that we've been using the word urgent for more than a decade now, and that has not changed. If you've been paying attention more recently, you'll know that that there's a strong appetite amongst direct service providers, among such as outreach workers, shelter workers, people in agencies, among people who use substances and lack stable housing, and so on. There's a real appetite for not going back to the same old, same old. And I know we're all kind of worried that that will happen once the pandemic closes out and the funding starts to disappear. But lots of really great stuff has happened to serve people who use unregulated substances and maybe lack stable housing in Waterloo region. I think of some of the work at the shelters, but we're particularly excited to invite Dana and Gab from Parkdale in to share on the ground experiences. They've got more than a year with urgent public health needs sites under their belt, and we'll talk about safe supply and so much more. So without further ado, I thank you so much for showing up to the webinar here, and I want to extend a special welcome to guests from outside of Waterloo region, some folks involved with municipal drug strategies are on the line from Six Nations, from North Bay and other parts. So welcome to all of you. I won't go through a long introduction to Gab and Dana. They're quite capable of doing that themselves. In the invitations, you'll see a bit of a biography and some really awesome links to more information. And the hope is from the 35 members of the Crime Prevention Council that following today's presentation, we can get to better right here in our own community. So without further ado, please welcome Dana and Gab.
Hi, everybody. Thank you so much for having us. This is a really exciting opportunity for both Dana and I to come together and share some of the work that we've been doing over the last year. It's been an incredible learning opportunity for us because I think everybody who's been working in harm reduction in various capacities has had to really figure out how to navigate a pandemic in addition to the navigating the toxic drug supply and all of these wild things. So just a little background on myself. I've been at Parkdale Queen West Community Health Center for almost 2 years now. Prior to that, I was in community settings, working in harm reduction, and I was looking back on my time, and I'm nearing 20 years in harm reduction, which I don't know what happened to time, but here we are. Yeah, today really gave us an opportunity to put together a PowerPoint around our services, and we're really excited to share with you. So I'll just pass it over to Dana for her introduction, and then we'll get started.
Hi, everyone. Just want to echo Gab and expressing gratitude for bringing us to this space today. My name is Dana Lexinger, and I'm one of the harm reduction managers at Parkdale Queen West Community Health Center. Primary role in the last year has been uplifting the integrated harm reduction initiative in the physical distancing shelter locations, in addition to a number of on-site harm reduction services and initiatives. I have a background in coordinating case management and frontline activities, also in the community of Toronto and in the West Coast in Victoria, British Columbia, coming from frontline case management and shelter experience myself. So looking forward to sharing and reflecting on some of the things that we've learned in the last year and some of the things that we've heard from the community that's really helped guide some of our practice implementations.
Just while we're getting sorted out, sort of Gab and Dana will run through our presentation. We'll take a 3-minute break at the conclusion there, and then it's over to questions and answers. And I was remiss in saying that we don't have two experts in the rooms beside me here, Sarah Escobar and Jesse Burt, both with formidable experience in Waterloo region. So they'll lob a few questions toward Dana and Gab and then open it up to the studio audience. At the conclusion of the presentation, you'll get a survey, and it means something. So we encourage you to fill it out and send it back. And we'll use some of the results from that survey to advance life-saving measures right here in the Waterloo region. So back over to you guys in Toronto.
Thank you. My goodness, I figured it out. So thank you for that support there. So the two pieces that I'll speak to you about today are the COVID recovery site and the Safer Supply programs that we run at Parkdale Queen West, and Dana will cover the iFair piece. So the first thing that we're going to cover is the recovery site itself. So this, I will say, has been probably the most interesting, or one of the most interesting professional endeavors that I've had. This was a response to trying to support individuals who tested positive for COVID that were residents of the shelter system. And so what happened on April 7th in 2020 is that we had basically a gathering of the partners involved in saying, hey, we need a rapid response. What do we do? The City of Toronto had leased out one of the hotels in the west end of the city. And, you know, having had nobody on board who's ever lived through or navigated a pandemic, it was a very interesting exercise in partnership as we all showed up on site April 7th, being like, okay, we have an intake tomorrow, we have no process, we have no real understanding of how we're going to move forward, and we have no understanding of what COVID is and how it's going to affect our shelter residents. So it was a very interesting piece to operate all those things at the same time as we're trying to have these intakes come in and support individuals from the shelter community. So when I speak of the shelter community, I mean everyone from any shelter system. So the folks that we saw have been individuals attached to violence against women shelters, family shelters. We hosted many individuals from the refugee and newcomer shelters. Lots of our population was from the chronic homelessness area, and we also had youth on site. So as we know, COVID manifests in the way that it does, and all of these folks were residing in our space at the same time. So we were really navigating like where outbreaks were occurring, how we were welcoming this wide variety of individuals, and how we were then going to navigate having their needs met on site. So as mentioned, the partnership was with Parkdale Queen West, or is with, we're still operating. The neighborhood group was providing peer support, so they had an entire peer team to work with clients on site. Inner City Health Associates was providing the clinical services, so they have 24-hour nursing. We had addictions on call support, as well as physician on site to do the triaging and intake and referral of clients. University Health Networks supported like the structural components like our PPE needs, IPAC requirements, technology requirements, and did some project leadership. And the City of Toronto was operations and contracted services. So for the cleaning, housekeeping, cleaning teams, and linen services, and security services, and food services. So that all came from the city. So when we look at the programs over the last, 15 months, we have supported two different programs. First was the COVID positive program, which was for individuals from the shelter system who tested positive for COVID. So they would be on a 10 to 14 day admission, depending on symptom onset. And in terms of unique stays over the course of the entire year, these stats are really only up till March, but because we had the massive third wave in April. This is not the complete numbers, but we saw over 1,350 people in the positive program. We also ran in the same building the COVID query program. So this was for individuals who were awaiting results, but since the second and third wave started, it was primarily focused on high-risk close contacts from the shelter system. So everybody that came on site was there for a 14-day stay. And we saw over 1,564 clients within that period. So overall, we have seen a great number of people come through the hotel. So we had a really comprehensive wraparound care team. We had the harm reduction team, and we had the peer support team. So I will say that this was probably the most comprehensive harm reduction experience that we've had the capacity to have. A benefit of the context of the pandemic has been that I think since everyone was just looking for any kind of solution to primarily support isolation guidelines, we were pretty much given opportunity to trial any type of program, which has never really happened historically in my career before. So we really tried to take opportunity to do anything harm reduction. And the first program that we implemented within the recovery site was our managed alcohol program. So individuals coming on site, it was incredibly low barrier program. I think traditionally in managed alcohol programs, we see a very specific set of eligibility criteria. In this particular case, we were asking people upon intake around what their, daily consumption looked like, and if, participating in a managed alcohol program would support their isolation stay. And that was essentially all it took to engage them in managed alcohol. We moved towards a demedicalized process. So this meant that the clinical teams were providing medical directives for the harm reduction team to actually do assessments and dosage for client intake. And that's a newer process that we've been doing for the last 3-4 months. And it's been going really well. And it is a really great example of coming together in a multidisciplinary way that's not hierarchical as you sometimes can see. So managed alcohol was a really phenomenal success with us, and was really interesting to hear the client experience of, you come on site, no questions asked, well, questions asked, but like not some massive interrogation and assessment process. And, we're like, here, let us give you a comfortable stay. So one of the things that we also engage, and this is, central to the conversation today, is the UPHNS application for the recovery site. So currently we have 2 OPS services. One of them live in each program. These applications were put in last May, and we started the program up, I think, about a month later or so, on July 6th of last year. So this was a very interesting process for us to go through, because it also, in terms of an application, was very low barrier. I was like, wait a second, where are all the difficult questions and community consultations and all the boxes to check? But it ended up being a pretty intuitive experience, and the approval period was very quick to respond to, again, the urgent public health need. The one downfall in Ontario is that the province has not enacted the class exemption, which would have permitted us to just lift up OPSs anywhere and everywhere as needed. We're still restricted to the fact that we have to submit individual applications at this time. In terms of other overdose prevention services, one of the learnings that we took, and this is, I think, very true for anyone running a hoteling program right now, for shelter or otherwise, is that, for a lot of people, it was their first experience having privacy and having comfort. And so the OPS might not have been as popular because everyone had a really nice hotel room to kind of spend their time in. And so what we saw as well is that a lot of people were like, thanks, but no thanks, I'm going to use in my room. So knowing that this was absolutely going to happen for us, we tried to come up with some strategies to support individuals to do so. So we had different witnessing protocols for folks. Upon intake, we would give them their options and say, if you want to call us and use while we're over the phone, if you want us to stand by your doorway, we can do that. If you prefer having a peer support person witness, we could do that as well. So really trying to engage people in their style of use. Something that came along a little bit later, I would say this probably became more active in June or July of last year, was in partnership with our clinical team, engaging in risk mitigation prescribing. So I'll differentiate Safer Supply programming from risk mitigation. Risk mitigation is the experience of a very short-term prescribing of hydromorphone, or I should just say long and short-acting opioids for immediate stabilization. Safer Supply more so refers to as kind of a longer term program. And so that's why we have different titles for similar practices. So this was a very interesting learning point, because prior to the pandemic, we saw the prescribing of Safer Supply as like, it had a lot of politics to it, and it still does. And there was a lot of negotiation. But as we saw COVID aggravate the overdose fatalities, there was a greater motivation to like respond to the need. And so one of the things we were able to enact in the hotel was this kind of rapid access to short-term safe supply. And so again, upon intake and assessment, we would establish what somebody's street supply baseline was, and if they were interested in doing like short-term risk mitigation prescribing, where they could get their hydromorphone and Cadian and whatever they were assessed to be best fit with. So that was a really cool part of the program. Some of the pieces that we also developed is the substance use menu. So, we had a lot of conversations as a partnership around, we are seeing large volumes of people who use drugs. They're coming to the site in this transitional way. They know none of us. We have no relationship with these folks. Like, how is it realistic to expect people to disclose off the hop what their substance of choice is? So one of the tools we developed was this menu that lived in everybody's room. And so when the peers would welcome them to their space, the menu would be there for them to fill out in their own time. And the harm reduction team would come around and collect the menu. And it was essentially an opportunity for communication and engagement with the folks that were staying at the recovery site at that point. And it created some breathing room for individuals to feel like, okay, maybe there is a choice. They could ask questions. They could choose to do it. They could choose not to. It was really up to them. But we did find that it was a helpful tool to remove the burden of disclosure and encourage autonomy of choice around conversation and substance use. And another tool that we developed in terms of crisis de-escalation was our Code Green. One of the things that we were finding within a multidisciplinary partnership is people's tolerance to aggressive, or what they like, quote unquote, I'll say, aggressive situations, or perceived or real threats of violence. When you have a multidisciplinary team with like closer or farther relationships with de-escalation, the interpretation of an event is really quite broad. And so with the Code Green, we kind of implemented it to be able to pause when a crisis was unfolding and have opportunity for huddle and organizing a plan to best respond to the client need and the crisis at that point in time, because we didn't want to go to like the most extreme place of needing to like call 911 every time if that wasn't going to be necessary. And it was a really good opportunity for shadowing and training around crisis de-escalation techniques. So that was a really helpful tool for us to use. In terms of the peer supports, we really tried to encourage points of connection. And so with the peers, they were always the primary point of contact. So when somebody would be taken into the hotel, there'd be a welcome call to explain like the process, answer any questions about their stay, and refer to either the clinical team or harm reduction team if there was specific concerns. One of the pieces that they would do would be coordinate wellness checks. And wellness checks is definitely something that we've had to negotiate over and over and over again over the last 15 months, because there's such a massive fear of overdosing and isolation that sometimes we forego client autonomy and do the over-policing thing with checks, which is not an evidence-based practice, because the likelihood that anyone would walk into somebody's room at the exact right time that they're overdosing is highly unlikely. And so we were trying to really encourage relationship as a method, as a primary method of overdose prevention. Peers were great with crisis support. The individuals that came to site were really responsive to connecting with the peer team. And one of their primary functions was accompanying folks for smoke breaks and exercise. So walking around the building, because, you know, asking 2 weeks of isolation in a hotel is quite a bit on humans. I mean, all of us have had to engage in isolation practices to some degree, and it's been hard on everyone. So there's particular challenges with our you know, shelter folks who might have associations of like this being a highly institutionalized practice. And so we really wanted to try to break that as much as possible. The peers were also great with the provision of resources. So we had gift cards, clothes, snacks. And again, a unique opportunity that presented itself in COVID is like when people asked for something, we tried everything we could to accommodate that. So if they wanted a phone charger, if they wanted, you know, support calling internationally, if they wanted anything, we would be like, we'll do everything we can to get it for you. So that was actually an amazing change from the usual massive limitations we face in harm reduction. So lessons learned, we really saw this interesting change. So because we were operating as a shelter, but we also were under hospital designation, having an OPS embedded in both shelter and technically a hospital made it kind of a first, allowing for precedent to be set around how we can further change the system post-COVID. As I chatted briefly about, the demedicalized process of MAP was a really great pilot that we were able to exercise over the course of our tenure at the recovery site. Again, SOS prescribing was so conservative prior to COVID, and we've really been able to expand, seeing the benefits of being able to tackle, you know, some huge concerns around the fatalities that we're seeing by responding with SOS. The recognition of diverse expertise is something that historically, I think that in multidisciplinary teams, I mentioned that there's hierarchies that we experience. And this was really like all teams were living so intimately with each other that I think that there was a really great knowledge exchange and capacity to learn from one another and really understand what our respective roles and responsibilities were. And it was really adaptable as a program. Like we saw things that weren't working, we changed them. You know, one of the jokes is that the program looked different every 2 weeks. So we were able to just change, and nobody was married to any particular idea of how things had to be. The client-centered approach, the integrated care model, the increase in partnership, was phenomenal. And again, like I mentioned, knowledge exchange between teams and the capacity to evaluate and have that model change was something that we were able to do. And right now we're participating in an evaluation of the substance use services at the recovery site. So that should be published in the fall. Challenges that remained were the philosophical differences between community and institutional approaches. That is like an old relationship that takes some time to adjust to. We really saw gaps in our communication tools because the clinical team was on their own EMR, the harm reduction team had their way of reporting, and the peer team had their way of capturing data, and none of them spoke to each other. So there were a lot of misses in terms of communication on site because of that tool issue. You know, we see traditional power struggles around like how best to tackle client care. So we really had to do a lot of work on our values and principles and how we took action on that front. On-site and off-site staff, we had some clinicians that were off-site, and it was very hard to get to know the client experience when working off-site. And so there'd usually be a more conservative approach taken to client care than being on-site, working within the embedded team and having a different perspective on clients. You know, decision-making was challenging because of all of the factors above. I did not finish my sentence here, but frequent staff turnover was something that we struggled with because it was precarious employment for everybody involved. We never knew when the recovery site and if the recovery site was going to end. So we were kind of going like month to month scheduling. And so we ended up losing a lot of people, having a bunch of new people, needing to reinvent the program. So those changes were difficult. And we all had different reporting bodies and accountabilities. So now I'm going to just move on to my other massive program, which is a Safer Opioid Supply Program that's rooted in the base site at Parkdale, Queen West. So the purpose of this program is to provide pharmaceutical grade alternative opioids to reduce the mortality rates for people who use drugs. Attach folks to primary care and support client advisories that are attached to SOS programming. So originally we kind of started SOS as this trial unfunded experience back in, late 2019, early 2020, and put in an application for SUAP funding. We got approval for SUAP in June and started being funded at that point in time for an official program. So I'll just run quickly over some of the objectives. So reducing the risk of opioid overdose, respond to the ongoing crisis that we're seeing, engaging participants who are facing barriers in traditional models of care. And this one's a particularly significant one because what we see oftentimes in substance use care is a strong focus on abstinent pathways. And so individuals who are in a different position have a very difficult time trusting primary care in terms of what they can and can't disclose about their substance use. We also look at reducing harms associated with illegal activities required to access drugs through the illicit drug market and support clients in initiating and transitioning to traditional OAT or IOs if available. So just to look at the programs that we have in place right now, we have two versions of our base program. So we have the daily dispense program, which is individuals who pick up their prescriptions at the pharmacy on a daily basis. And we have individuals who participate in the observed arm. So this is only at our Parkdale site. And the observed arm is specific to folks that have multiple complexities. So if they're using opioids or opioid analogs plus benzos plus alcohol plus significant physical and mental health concerns, they would be qualifying for observed arm. We also have a strong focus on BIPOC, queer, trans, and women communities because these are often communities that have even greater fractures in accessing healthcare. And so our staffing structure for the SOS program is really quite good and it's very comprehensive. So we have 3.5 MDs, we have one NP that's, or 1.5 NPs, I should say, that's attached to the program as our prescribing body. We have an RN at both our sites. The RPNs are the ones that run the observed arm. We have 2 case managers, 1 at each site, 2 health navigators at each site, a project manager, and the SOS manager, which is me. So the case manager and the health navigators work really closely together. The health navigators are mostly focused on task-specific, short-term task-specific needs that our clients might have. So focus on accompaniments, processing some paperwork, getting signatures, and the case managers focus more so on long-term complex social issues, so housing, legal issues, complex healthcare issues. Our project manager is committed to the evaluation component of the program and a lot of the admin and program structuring because we are still very new. We just left our pilot period March 31st and have now engaged in our 2-year extension. So there's lots that we're still trying to figure out as a program. So some of our funded activities are the development of client drop-in opportunities. COVID has kind of put a stop to that, but hopefully we have a light at the end of the tunnel where we can start engaging the community again. We are participating in the new National SOS Community of Practice. So if there's any providers or harm reduction healthcare folks on the line, this was a newly funded program from SUAP as well. That looks to bring forward the expertise of anyone interested or anyone doing SOS to really have a center of support, because one of the biggest pieces of feedback with Safer Supply is that, you know, people end up doing it in isolation a lot, and they don't have a community that they can rely on when they have a complex case that they want to figure out. So this community of practice is very, very helpful. And anyone interested, I'm happy to link you up with the program coordinator for that community of practice. We look at doing a lot of program promotion. Again, the advisory council, we have 2 of them. We have a general advisory and we have an Indigenous specific advisory to really help shape and develop the program and troubleshoot some of the struggles that that we face as the wraparound team or the clinical team, and engaging in a program evaluation at the end of it all. So our targets up until 2023 are to serve 175 unique clients. So over the first over the first 6 months of our program, we were looking to serve 100 folks, and we've definitely met that. So hopefully we'll have these 175 more. So again, benefits and challenges. Clinical protocols was a really significant piece to work on, because we, again, are looking at starting a program from scratch that doesn't have historical frameworks. So we really needed to look at every element, whether it's the wraparound protocols or the clinical protocols of how we do what we do. Increasing awareness of the SOS program with the local and federal politicians. This is significant. Looking at increasing linkages to care, client stability over time. The observed arm is phenomenal because it really provides a deep continuum of care for individuals. The goal of the observed arm is to have people be able to move to daily dispense. Provider capacity building support exists within our current funded program. The National SOS Community of Practice is a great benefit. We have a robust team, and we have, you know, as close as to an endorsement as possible with the CPSO, and SUAP has released statements about SOS encouraging that practice. So the challenges that we're still facing are lack of support from the province, a massive struggle with burnout because there are so few providers providing SOS that they carry an enormous burden. Provider limitations. So again, in terms of hiring and seeing who else is interested and available, there's struggles on that side. The work ends up being quite siloed because people are oftentimes outside of funded programs working on their own. Sustainability is always the question that we look to answer, and structural issues. So attached to like earlier evaluations of safer consumption spaces, you know, looking at meeting clients where they're at is a significant piece. We're aware that we function out of a health center, and that might not work for all the clients that we need to see. So luckily, we've had a small expansion in our SOS team and are soon lifting up a mobile SOS program with 2 NPs, 1 RN, and 1 case manager. So hopefully that reduces some barriers for some of our clients. I'll pass it over to Dana now.
Hi, everyone. So my role has been coordinating and collaborating across the city with the iFair initiative, which is an integrated prevention and harm reduction initiative, which the title has been very confusing for everyone because in this case, the E stands for initiative. This was titled by the City of Toronto, and essentially the iFair program is a response to COVID as we saw things happening rapidly around us, and the needs on all of us to implement physical distancing measures. What was happening, as we all know, was that shelters were having to moved to provide space so that folks could safely distance themselves within spaces, which then left several folks outside. And the response to that was to, similarly to what Gab was speaking to around the 4 Points Hotel, was to move shelters into vacant spaces across the city. And folks who usually would be staying in a shelter environment were moving into individual hotel rooms. And what we then saw, of course, was a rapid increase in overdoses. And that's due to a number of reasons related to the toxicity and unrelated drug supply, isolation within the space. So folks were consuming alone, where oftentimes folks would be encouraged to use within their communities and work with one another. This was restricted due to sheltering folks in isolated spaces, reduced number of congregate spaces for folks to gather together, and shelter residents moving across different sites and therefore looking to engage with sellers who they may not have a previous relationship with, increasing their risk for overdoses. So we were seeing this happening across the city, and the intention was to look at how we could implement some more harm reduction supports on site, where traditionally shelter providers, they provide the housing space, but don't always have the background, the knowledge, and the experience around what harm reduction looks like within these places, not supported within their policies, and we're seeking ways to increase safety, support, and isolation. So what ended up happening in November of 2020, the city approved funding for the iFair initiative. And in December of 2020, we were able to start hiring staff members across the city to look at integrating programming in multiple sites across Toronto. Gab, do you mind switching the slide? Thanks. So this initiative is a multi-pronged approach. Okay, I just jumped ahead of myself, sorry. So no, go ahead, that's good. So the goal or the objective of iFair is to increase harm reduction knowledge and practice within sheltering locations, connect residents to community resources and community clinical support so that other needs that they identify within their lives or expressed are being met within their sheltering location, decrease in resident isolation, and increase in overall well-being in whatever capacity or way that might look like and however they identify that as being, and engage residents in harm reduction, providing a range of options, tools, and solutions to increase their safety within their substance use. Next. So the development and the approach to the iFair initiative is multi-pronged. So we have the City of Toronto funds this program, and TGRIP is the funder. The shelters provide and manage the sites of the environment where folks reside and stay. The harm reduction teams implement harm reduction services are all attached to community health centers across the cities. And then TNG, which is the neighborhood group, they train peers and implement peer development opportunities and harm reduction supports within these residential settings across the city. So these were the partners. So we have 3 staff coming from Parkdale, Queen West, harm reduction coordinators who are employed by Parkdale, which is the CHC that I'm affiliated with, Sherburne Health, Street Health, South Riverdale, Regent Park, and LAMP. So these are the number of funded harm reduction coordinators associated with the health center. And then the shelter providers that we have are Dixon Hall, which has two sheltering locations, Homes First, which is our biggest shelter provider. They have 4 hotel locations across the city, Fred Victor, Costi, Street Haven, Good Shepherd, and St. Felix. So as I mentioned, the peer lead is the neighborhood group, and they have 2 coordinators who provide harm reduction peer-led training at a integrated level, and then also for the peer witnessing. And when we look at all these numbers together at the population capacity within the shelters, that is about roughly 1,500 potential residents across the city who are residing in these shelters. So looking at what the roles are in terms of harm reduction integration, what does that mean? I mentioned in my introduction, a lot of the integration is led by the expressed need and identified interest of the residents themselves. But some of the things that are provided consistently across the sites, and we recognize that each location looks a little bit different. The population might be a little bit different in terms of what the chosen substance is, the age range, etc. And not to mention that these hotels are spread out literally all over Toronto. That also changes a little bit of what the sheltering needs are for the residents. But some of the harm reduction integration practices and activities that the coordinators provide are, basic access to harm reduction equipment and naloxone, and creative solutions and ways of making that happen, recognizing that, even though a lot of shelters do provide kits and naloxone on site, there is challenge for some folks to, attend the shelter provider lead to access kit, because they recognize that that could stigmatize them and put them in a place where there's concern that it could impact their housing. So there's been some creative solutions that the coordinators have provided on site so that there's some more stealthy and intuitive ways of folks accessing and disposing of any of the equipment that they might be requiring. So some engagement groups, drop-ins, and chill spaces. This has obviously been impacted by Toronto's lockdown, which has kind of been never ending, but the groups have been implemented based on some of the expressed interests from residents, whether that's just an engagement group to socially gather or specific groups based on an interest to increase knowledge around a particular topic. The drop-in space is essentially a coffee zone for folks to come in, sort of suss out who these folks are who are linked to the CHC, and an opportunity to engage and build a relationship. And then the chill spaces for sites that don't have an OPS currently are essentially a place for folks to casually use and do what they need to do, where there are staff around to support them as needed. A big piece of the implementation is workshops and training for staff, so that shelter staff can identify and respond to an overdose on site, which is been an interesting part of this endeavor, because there's been historically in some locations a resistance around responding to an overdose in terms of what roles are, and seeing that more as a harm reduction piece rather than a collective response from all staff involved in a location. So building comfort, building confidence, and just running drills around how to respond to folks, and also how to continue building that relationship post-response as well, because we recognize that that can also have an impact on engagement for shelter staff and folks who are tied to those spaces as well. Peer witnessing and phone spotting, which the phone spotting has been really helpful while we've been restricted around gathering in spaces, and it's flexible and adaptable to the comfort level of the individual as well, and just can basically be like a call to the harm reduction coordinator. I'm in this room, going to be doing this. If at this time you haven't heard back from me, my door is unlocked, and essentially making a plan. So we also have been able to uplift access to point of care testing and home HIV tests on site. Looking to more low barrier social activities. This has been a goal for a little while, but unfortunately, as I said, we know COVID has restricted that. Connecting folks to safe supply and health resources. A number of the sites we are fortunate are connected to Inner City Health Associates, which is clinical supports on site, to look at things like wound care or whatever kind of clinical health needs and medication pieces might come up for folks that can benefit them or they're interested in engaging around pertaining to their health. We're looking at uplifting and have been able to uplift at a few locations safe consumption services, which is oftentimes dependent on space, neighbors, which is a piece that we are recognizing in certain locations in the city. There's some pushback from some of the folks who are residing around the sites. The peer support training, the healing circle in traditional medicine has been extremely impactful and important for populations in our some of the sheltering sites where we're seeing a lot of Indigenous folks. It's extremely meaningful. and low barrier counseling, crisis support. And anything else in between, as Gab was saying, a lot of flexibility, adaptability, and creativity around whatever folks are needing. We want to be able to provide solutions for folks to have their needs met in a way that's going to keep them safe and keep them happily housed within their shelter. And the fortunate piece around, we've been going for 7 months now, I guess, is that we've really been able to start building relationships with residents. That can obviously take time. I know that we understand that, to really get to some of the core pieces around like where as staff and frontline supports we're missing the mark and need to look at creative solutions to implement more accessible harm reduction supports. Next. This is just a photo that I provided by one of our CHC harm reduction coordinators from South Riverdale Community Health Center. This is a shoe rack. It's an example of something that almost all of the harm reduction coordinators have implemented on each floor. So there's everything that you can imagine that someone might need with resources and some advertising around the side around like where you can find the harm reduction coordinators. This is an intro to a couple of the harm reduction coordinators and where they can be reached so that folks can come to them when they feel comfortable, and it's not staff constantly trying to engage with folks who may not quite be there yet, but they can access what they need here and not have to engage with anyone if they don't want to. Some creative solutions. Next. This is a screenshot of some of the data that we're collecting to try to shape what it is that we are doing on site. Some of these requests are specific asks from the city so that we can show that we're doing the work that they're funding us to do. But we've also added some of our own interests to report data that we can get more of a rounded view of what's really happening on site. So this is just for the month of May, and it is including all the CHCs within the partnerships. But you know, it's great to see that we have so far, for everyone who's put in their May data, 235 harm reduction clinical supports linked to care. So it gives us an actual idea of like what's happening on the ground level. And the number of trainings that we've been able to push out to increase some of the capacity of shelter staff and collaborations on the ground level to ensure that everyone's responding and increasing their knowledge and competency around harm reduction. Next. So as I said, 7 months, it's gone really fast, but it's we've learned a lot in a short period of time, but I think that we still have quite a bit of work to do. Some of the benefits that we're seeing in this period of time is a general increase in harm reduction. Us we're used to kind of being told no, hitting a wall around implementing realistic supports. Often more of an openness to at least engage around what these solutions can look like, and even just an openness to try them on site and engage with the expertise of the harm reduction coordinators to learn more about what these practices are. So we're also seeing increased partnership and collaboration across the community as this multi-pronged approach. It's been a really great approach. It also brings so many different backgrounds and experience together so that we're able to utilize a lot of different knowledge bases and lenses to look to support folks more meaningfully and draw from each other's experience and learn more about each other's programs and services and resources in the community. And where there is a gap, we're able to tap somebody in to increase some knowledge and to really figure out a quick way to make things happen on site where needed. We're seeing a lot of creative solutions to increase safer substance use and practice. The phone spotting is a really great example of that. The shoe rack is another piece that, like, it's something so simple and so easy that's really made a big difference for folks. We're seeing finally a really great value in the peer expertise and providing opportunities within the shelters. So, you know, Gab has spoken very openly about all the amazing work that's been going on at 4 Points with the peers, and now we've been able to draw from those folks to bring them into our spaces and look at ways of, again, where we can increase engagement and solutions on site, and it's just providing more equitable employment opportunities. Great knowledge exchange and resident connection to resources and referrals. So because we have a lot of different things going on in one space, we're able to make speedier referrals and connect folks to services without those gaps in the wait lists. And if somebody has a connection somewhere, they're able to make that happen in a bit more of a steadfast way so that there's not broken up service where folks then are delayed in accessing care. And also, I think that when everything is on site, it's just easier for folks to engage with and actually attend to. I mean, for me, for sure, that's that's a huge benefit. And engagement and interest to respond to ODs, as I touched on just earlier, it's not just seen as a harm reduction piece anymore. It is seen as a collective health measure for everyone to engage and respond where needed, and adapting it as a baseline policy and procedure within a site rather than a thing that those other people do. Some of the challenges that we are engaging with due to the wide number of different sheltering residences that we're working with is there is some challenge with value dissonance. Some of the locations come from an abstinence-based background, so this is really a learning curve, and really looking at ways of demonstrating the value of harm reduction and showing how it is a practice that increases safety. And a lot of the traditional ways that the abstinence-based programming have been facilitating their residential services actually is counter to what it is that they're trying to achieve. So there's been a lot of work in some of these locations around getting to that space. Reconciling policies across agencies has come up a few times. Sheltering sites obviously have certain policies that they need to abide by that look different for different agencies who are not tied to sheltering spaces. So, for example, wellness checks is a piece that's been, Gab has touched on, and it's something that's ingrained as a part of like a piece that these shelters need to do to ensure that folks are safe within their spaces. It's something that's quite counter to the approach of many of the CHC harm reduction coordinators. However, there's been a lot of great dialogue to reshape and approach wellness checks in a more engaging relationship building way so that it doesn't actually decrease safety for folks. And we're getting to a place where fortunately we've been able to start looking at reshaping those policies within site. Staffing changes, as Gab said, there are a number of locations that are very, very large, and they do rely on external staffing models, which means you don't know who could be coming on site at any day. They may not have any experience working with community, may not have any in prior engagement with folks who are impacted by social inequalities and substance use. Continually engage around like what working with folks looks like and what harm reduction is. There's definitely been a bit of resistance from some staff around even willingness to engage with the harm reduction coordinators to even discuss like attending a training just for them to even feel equipped and prepared to engage with someone as needed if they do go into overdose. That's been a barrier, not at all sites, but at some. Communication strategies with so many people on board, that's come up a couple of times, especially when reporting outbreaks. So what that looks like, staff coming on site, not knowing if there's an outbreak, does this person need to isolate? All these pieces are things that we continue to work through our millions of meetings that we have weekly. Defining roles, a number of the harm reduction coordinators also are working alongside harm reduction staff who are tied to the sheltering sites. So it's who does what, where do we collaborate? Are they case managers? Can they do this? Are they assistants? These kinds of things that we're constantly having to redefine and reaffirm with the staff. And the general bureaucratic procedures that sometimes we face that can slow down processes. So especially pertaining to looking at uplifting OPSs within locations, definitely community pushback in many spaces, and also just moving towards quicker solutions to allow this to happen. It's been faster than the past, but we're still looking at creative ways to speed up these processes, because we obviously don't know how long these spaces will be available to us, and wanting to ensure that folks have as many available resources as possible is ideal. I think that is the end of my slide. So that is IFAIR for everybody, the Integrated Prevention and Harm Reduction Initiative. So thank you for listening.
Thank you so much for presenting. That's no small thing what's going on there in the YYZ. And kudos to you and your extended networks for the amazing work. We've gone through a somewhat similar experience here in Waterloo region, and I think Gab mentioned that there's a bit of license to be creative in a way that wasn't possible before. The barriers simply didn't exist; they evaporated, and some of the funding was available. And I think I mentioned they're a little bit worried that we'll snap back to the same old, right? And so, yeah, all the best in your work going forward. I think we'll skip the break just in the interest of time, if you guys are okay with that. We have about 25 minutes left, and there's more than a few questions in the Q&A section. So for participants who have questions, lob them in there. Be succinct if you can, and we'll try and get to them. Sarah and Jesse are hanging around in the background here, but they've seen some of those Q&A questions, and they're not dissimilar. So we'll cut straight to it. But if I can, so you've had some funding. I don't know if you. So what can I say? There's definitely interest here, and some aspects of what you've described is happening here on a smaller scale. Like we're not meeting the demand here across Waterloo region. So some of that pandemic prescribing in isolation spaces, whether it's alcohol or hydromorphone, some other activities, that kind of thing. So could you talk a little bit about funding opportunities, like some of the structural stuff? So that's where I think what we're hearing from providers here is, well, it's great, we could open a UPHNS, but who's going to staff it? Where's the money going to come from to do that kind of thing? And I know there's a mix across the province, but yeah, I don't know if you could talk about some of the options that might work for us here in Waterloo region.
Yeah, the funding piece is really dicey. It's hard because we had the opportunity to have the UPHNS exemption, which is phenomenal, but it's just the exemption. It's not really anything with a funding allocation attached to it. And so I think that in the places that we have been working on, so I'll talk about the recovery site, and I'll talk about some of the work that Dana and I are doing with some of the shelters to lift this up. Is the recovery site, again, it's technically unfunded, but it's the model that we applied was a 24-hour on-call model. So the staff that are working regularly within the site, and I forgot to mention, it is a 24/7 service with peer harm reduction and clinical. Everybody works on that schedule, that people will call the harm reduction office to get supported. So it's not like fixed staff is attached to that space, and that's how it sort of worked for us within this structure. And again, it's so individual with wherever the space may be around how you allocate staff to it. The way that we have operated with IFAIR is we are working with one of the downtown respites to lift up an overdose prevention service within the space. And I think one of the pieces that is really integral in that part of the conversation is that this particular space has seen over the last probably 5 years an enormous amount of EMS calls related to overdose and the staff performing overdose response services anyways. And so right now, the work that we're doing is to then just attach a physical space, and they're still going to do the work that they're going to do. And I think our preliminary model is employing that on-call piece, where it's having then a person wanting to use the space just nudge staff. We're looking at doing a blended model for that respite, where the primary responsibility lives with the respite staff, but we're looking to build out peer supports of residents who want to become engaged, because there's also that social rec element and meaningful involvement element that people in the respite center have voiced wanting to participate in. And so here's an opportunity to have some paid work to support your friends, your family in accessing space. So building out a significant peer body to do that. And we're also looking at embedding some of the IFARE coordinators that are attached to the space to do some staffing support. So a lot of it is very reliant on partnership because it's not an explicitly funded model. And so the best advice I could give so far, whatever my realm of knowledge is so far, is in how you build out the partnership and how it becomes integrated into the work you're already doing. So many spaces, whether it's a community health center or a shelter, are doing overdose response work. And so how do we then kind of provide the tool or build out the tool to do a more coordinated effort around that work? It is complicated. It's not simple, but it's doable. And it just requires, understanding like who's involved, how do we grow out the partnership, or how do we build capacity internally to embed this program. So those are the preliminary conversations to have to best support it. And I think that in terms of funding, there is a growing appetite to support overdose prevention services and safer supply provision. I think we're going to see more funding. Maybe I'm just optimistic, but I think that we are going to see more funding from SUAP come down the line to support safer opioid prescribing. And the world of SOS will expand as well because, I think there's an enormous amount of community advocacy right now around the options for what is being prescribed to. So I think that there's a hopeful future.
Well, I like your optimism for sure. Just last question, if I can. So I do like your optimism, and you're right. There's a groundswell, and people are ready to go. The integration piece we've done fairly well here in Waterloo region, particularly among community agencies, and the pandemic just accelerated that. It sounds like it did in Toronto as well. The iFair initiative that was funded in part through the City of Toronto. Is that correct? Was that a council decision or coming out of funds, maybe the federal funds that flowed into the city or elsewhere? Or did it go to council, or was it just a straight out of?
Not that I'm aware of. I don't even know. That's a great question.
Okay.
Yeah,
well,
it's funded by the city, by TGRIP, and they flow funds to the CHCs to provide the harm reduction services and support that are required within the spaces, and that's also where like staff salary and program planning funds all come from.
That's amazing.
And I think that's also where the peer salaries come from as well. So it's
right,
just flow through to the CHCs.
Nice. So moving to the questions, I'm just going to go in order. Question about how or which of these services can be implemented in a municipality that is hostile to progressive solutions, particularly overdose prevention and consumption sites. And then second part of the question is if there's any local groups in Waterloo region looking for maybe UPHNS stuff. So interesting chat. So to the questioner, I would say reach out to our office if you're interested in establishing UPHNS. There is a bit of momentum, but for the first part of the question, I don't know if you guys want to take that. There is lots of hostility and a different reaction to these kinds of multiple crises that we don't see with other important but less common forms of death and injury. Maybe you have some tips for us.
I mean, yeah, sorry, Dave, do you want to go?
I was just going to say that in anticipation that there would be a lot of resistance, the city got ahead of that and automatically started sending out invitations to all of the neighborhoods around information and engagement sessions where they would provide a full background and review of what the work is with the information, the data, and the research to back it up, and provided them the forum for community members to respond and ask their questions. And they did that several times to keep coming back to neighborhoods to engage with them, develop a relationship, and get the buy-in around why this actually helps your community and how it actually does support your neighborhoods. So the city got ahead of that well in advance. Obviously, there was a lot of pushback, but then that's where ground community initiatives also came into play to do the relationship buildings on the ground to continue developing the ground relationships with folks to start to meet the staff who are providing these initiatives. There's a lot of myths around what this kind of work looks like. and providing the opportunity for us to actually like share what our piece is in it, so that if they do have issues that come up, they can connect with us directly, and they already have the engagement so we can directly address that. Still obviously not perfect, so I'll let Gab jump on the other side of that.
Yeah, I mean, I think that the hostility piece is a very common experience for anybody trying to provide harm reduction, anything. You know, like Richard had spoken to this, anytime there's something that triggers people's issues around morality, you're going to be faced with this. So whether it's the early HIV/AIDS crisis, or we're looking at the overdose crisis, there's like those moral components that drive the hostility. And so I think one of the pieces to note is just to expect it. I know that really sucks, but one of the pieces is also with community consultation, town halls, and the due diligence and engagement, it's also not going to determine the program. So it's not saying, yes, we have to wait for 100% community approval to do it. We have to do our bit to show our evidence-based practice and our engagement efforts and our good neighbor gestures, essentially, but saying, nonetheless, there's a public health need that requires addressing. And so do continual education on it, but the consultation will not make or break the program. It's just a consultation, and the capacity to move forward is there. And I think that back when we sort of faced this at the health center, this sort of predates my time in 2017, 2018, when the Safer Consumption Services were being funded. So the CTSs, as they've been rebranded, consultation was mandatory. With the UPHNS exemptions, consultation is not mandatory. And so it does not prevent you from having the service, but there is a due diligence that I think that, you know, anyone within this work has to do.
Yeah, you have to infiltrate the meetings on the ground level and kill it with kindness. That's always my motto.
Good motto to have, yeah. And I think that the question, I mean, yeah, it's fascinating to hear, like, at the end of the day, you know, consultation is important and engagement, but at the end of the day, you react based on the life and death crisis that it is. So, yeah, good approach. A couple of questions from about the safer supply type of program. So any unforeseen issues with risk mitigation when people leaving the program? This were you prioritizing for safer supply upon discharge? Yeah, so I guess I think you understand the question, but you've got a time limited kind of, well, I call it pandemic prescribing, but and then it's going to end, right? What happens to those folks?
Great question, and 100% true. That's a huge gap in service that we have. So, you know, there's a lot of back and forth around the risk mitigation prescribing, ultimately landing on, you know, moments in time where you can provide support. The issue is obviously continuity of care, and we really struggle with that in Toronto because there's such limited prescribing that happens. So post-discharge from the recovery site has been challenging. I will say that the clinical and harm reduction and peer teams have really hustled to find some alternative, some way to support people in their transition out of the site. You know, we have had some folks that have come on site and have had rapid titration and stabilization and like have done okay. Other people have really needed like complexity service, such as the observed arm that we've had in Parkdale. And so, you know, a lot of it is just really trying to find a way forward for folks that can't be connected to a safer supply program, which is part of the burnout factor because it's not ideal. It's not ideal. And so, you know, you're doing the best you can with the exceptionally limited resources, so that there absolutely is risk. But again, I think it's providing that opportunity of a primary place of contact. And, you know, there's the benefits that come with the short-term piece is like knowing that there's an opportunity, knowing that there's a place for advocacy, that you can ask for what you need from your primary care provider, you know, that you've built a relationship and that you have a supportive network that's trying to transition you to somewhat of an appropriate post-discharge plan. I don't know if that answers the question, but it is that we just have very few services for folks post-discharge at the recovery site. And yeah, there are risks.
Yeah, well, it's an answer. It's a challenge, and I think last week or the week before, I mean, someone, a client or patient person, exited a program in another city, not Toronto, not here. They're cut off the safe supply, and they're dead now, right? A preventable tragedy, and doesn't that create so much burnout for all of us involved? There's a second part to this question, and that is around sort of the observed dose. I guess at initiation, is that when that's probably when you're doing it? Any other folks having any challenges with timing constraints? Like, are you 24 hours? Can you talk about a bit about the referral and the wait list protocol challenges, what's working, that kind of thing? I think we're in a similar situation here. Like, there's so much demand for safe supply, so many people who would absolutely qualify, if you will. It's very hard, but yeah. So the questions around observed use.
Yeah, so upon RN assessment, people are determined whether they're fit for daily dispense or that they require the observed arm. So not everybody is started on observed arm. Observed arm is very specific for complexities of health. And the majority of the folks that we see on programs start with daily dispense. So that's one piece. I know that historically and politically there's negotiation around, well, everybody should be observed when starting, but that's not necessarily the case, because it's really dependent on what their patterns of use are, the substance of choices, and like how that then materializes. I think that there's some clinical anxiety sometimes that encourage that sentiment, but I think that with practice we're seeing that that's not the case for everybody. And it's a real individualized assessment and start. Going to your referral and intake pathway, this is where I disappoint everybody all the time in saying that, like, given our limitations, we definitely are at a bottleneck, and the majority of the SUAP funded programs in Toronto are generally at capacity. So there's like a trickle in of new clients when we have one or two spaces. But I think that that's part of that piece, is that we've not had the opportunity to really trial specific referral pathways or processes because we just have not had capacity. So that's a systems and structural barrier that we continuously try to navigate, and the national community of practice is definitely trying to tackle this issue too by doing rapid capacity building with individuals interested in prescribing. So it's a really complex issue. I wish we had flow, or more so I think everybody does. But I'm hopeful that in the next year or so we can find some kind of movement that further expands the SOS practice.
And if I can, so at the Parkdale site, you have some safe supply prescribing happening. Got some SUAP that helps a lot. It's 2 years on the SUAP that you have. Is that right? Yeah. Around the prescribing, is it limited to opioids? I know it's in the title, but are you doing anything around stimulants or benzos?
Yeah, so it's primarily focused on opioids, but there is stimulant substitution. I don't know. I truly just don't know how frequently we see that. I can speak for the recovery site that the stimulant substitution risk mitigation prescribing was actually the first thing that we did there, but that didn't have a lot of participation in it over time. I think you had an opportunity to kind of trial safe supply with stimulants, but the massive demand was around fentanyl analog substitution. So this is where we primarily focus on opioids.
I have a question about the shoe rack with the supplies on there. It caught someone's attention, and I'm just trying to get to the question while I do. We had a shelter where it's similar kind of thing. We didn't use a shoe rack. It's a good idea for the future. We used whatever container was available, and people could help themselves, and it worked. But the question is for you, Dana, around harm reduction supplies on the walls. Are the cabinets self-serve? And if so, how is participant information collected for reporting / tracking purposes?
So they are self-serve. They're repacked every single day, so folks can access them 24 hours a day. The harm reduction coordinators will take a whole bunch of supplies from the CHC and mark it down in our tracking system, which is city-run, called NEO. So they track it off the back end of it, and they every single day they repackage it on the shoe rack so that folks can come and go as needed. And data related to folks is not actually tracked. It's all anonymous. So yeah, they can roughly get an idea. They know what they put in every day, and they know what's gone at the end of the day to get an idea of trends and whatnot. But there's no need for folks to actually provide any information about themselves in accessing any of the equipment. And another big part of having the low barrier access is that, as you can see next to it, it also has all the information and availability of different services on site. So folks can, it's just a gentle touchdown starting point for some folks, but it's entirely anonymous.
Okay. And were there naloxone kits down there at the bottom? Nice.
Yeah, along the bottom there, which was another piece that was tricky in the pandemic. Was I'm sure everyone's aware, a shortage of intramuscular naloxone because the syringes were being pivoted to stock up for the vaccine. So
Right.
that was another interesting challenge because folks often prefer intramuscular. But yeah, everything that folks need are there: kits, individual supplies, naloxone, and other resources.
That's awesome. Yeah. And often, I mean, one of the shelter experiences here is guys would pick up at an agency and drop it off. So it never ran out. It was great, actually. And did actually save some lives. Have another question. Interested in knowing if we will have an opportunity in treatment with Safe Supply to actually wean the addiction. Also, what role will the health community / hospitals, doctors, etc. play strategically in Safe Supply? Yep. So I don't know if you want to make a quick comment, Dana or Gab. We talked about this a bit last night, I think, on the webinar. Safe Supply, not offered in a treatment sort of context, like with the goal of abstinence or whatever those treatment goals might be. It might have, but we talked a little bit about how providing Safe Supply is treatment in a way, right? In the way it can enable housing stability, in the way it can reduce victimization, reduce overdoses, except all these social determinants of health, which for how many decades we've been so-called committed to advancing those. But I don't know if you want to take a run at the question.
Yeah, so I think I could just speak for like what our funding mandate is and some of the values and principles. So there's not an abstinent focus in how we deliver the service. If the client specifically has a goal of abstinence, then their provider and the wraparound team will definitely support them achieve that goal as much as possible. But a lot of folks that come to us as well don't have a goal of abstinence, and so we support their goal of stabilization. And so, like Michael spoke to, one of the biggest factors that we really try to work on are the social determinants of health. So one of the benefits that has really come through is that stabilization piece, where people have been able to reconnect with their family, have been connected to HIV, Hep C care, have been connected to housing, and those stabilizing factors really impact the quality of life. And that's essentially what we're striving towards. So it's completely dependent on what the client goals are as they enter the program.
Yeah, interesting. You mentioned connection to family and friends. We and Jesse delivered many of those in interviews, but Jesse would probably say that it was the longest pause in the questionnaire that we delivered. What would happen if you went to a pharmacy or a clinic, or you had Safe Supply delivered? And I think he said many times, it was the longest pause as it blew people's minds. And then the first answer was reconnecting with family and friends, right? And we all heard that the opposite of addiction is sort of connection and that kind of thing. Interesting, it comes up in Toronto as well. We are really out of time here, and I guess in the good news, I'm off to a potential funding meeting, so maybe your optimism will carry through for the next hour or so, Gab. I do want to encourage participants to fill out the survey that's going to come your way. We actually do use it. It does matter very much, and at some point, I would guess early next week, we'll get the recording of this presentation up on website, overdoseprevention.ca. I would encourage participants to start sharing this presentation and some of the other materials. You guys have done an amazing, I'm not just saying that, it's an amazing and an impressive body of work, and I know it comes with a lot of sweat and tears, and challenges in it, all that kind of stuff. But on behalf of everybody at the Crime Prevention Council and the studio audience here, and thank you so much for sharing your time and talents with us today. And if we could ever return the favor here in Waterloo region, or you're just looking for a road trip post-pandemic, do drop in. We're only an hour away. You're welcome here anytime, seriously. Thank you so much, everybody, for your time today, and all the best. Be safe.
Thank you.